Good morning. The title of our presentation is Depression, Its Characteristics, and Sleep Quality in Patients Experiencing Chronic Pain. Pain is the commonest reason for people to present to hospital. It is distressing to the patient, but it is an important sign for the physician. It helps in diagnosis as well as measuring recovery. But that is acute pain. Chronic pain actually serves really no big purpose, and it leads to complex, interrelated physiological, immunological, psychological, and social disabilities. And I'm sure the audience here can appreciate the relationship between psychological morbidities, such as depression and chronic pain, and how they confound each other. There are pain clinics at various levels of development all over Sri Lanka, and there are very well-established pain clinics at the Maharagama Cancer Hospital and at the National Hospital of Sri Lanka. The National Hospital of Sri Lanka has a multidisciplinary team-run pain clinic, and our study was based here. The specific objectives of our study was to assess the prevalence of depression in chronic pain, categorize the severity, and identify any associated socio-demographic and clinical factors related to the depression. We also understand that sleep quality is a prominent entity in chronic pain, and we also went on to study the prevalence as well as the associated components of sleep quality with regards to chronic pain. This was an analytical study, and we calculated the sample size to be 138, which aimed to detect a prevalence of depression of 10% in patients with chronic pain. So chronic pain was defined as patients experiencing pain for more than 3 months. And we excluded patients who were known to, as we were looking at the consequences of chronic pain, or chronic pain as an etiological entity in depression, we excluded patients with a diagnosed psychiatric illness and long-term medical conditions known to be an etiological factor in depression. These were our data collection instruments. The CES-D was associated with a clinical interview, was used to assess depression. This was validated by our team. The Sinhala version was validated by our team a couple of years ago. We used the PSQI, the Pittsburgh Sleep Quality Index, to assess sleep quality. This was again, the Sinhala version was validated by us. The numeric rating scale and the pain clinic records were used to assess pain, the severity of pain and pain-related clinical factors, and the PI interviewer-administered questionnaire to assess the socio-demographic factors. So there was an almost equal distribution between the two sexes, and this was the patient population was predominantly from the Western province. Now, this is an interesting slide. This is the occupations of patients. The occupations of patients were classified according to the International Standard Classification of Occupations. The orange bar depicts a number employed in various occupations prior to be given a pain diagnosis. And the blue graph depicts their occupation prior to the diagnosis. And the interesting finding here is the loss of occupation in almost all skill categories, and how the unemployment bar, that is the bar at the very top end, has elongated after the pain diagnosis. This table shows the mean initial pain score when the pain diagnosis was made, and the current pain score when the study was conducted. Majority had neuropathic pain. The variability in pain was, there was an equal distribution between pain at rest and movement. These were the body sites involved. And as you can see, back pain was, majority complained of back pain. Distribution of pain quality was assessed, and again, shooting type of pain, dull pain were more predominant in this pain population. As this was a very specialized pain clinic, invasive procedures were done on most patients, such as joint entheses, injections, spinal surgery, disc surgery for sciatica, and ketamine infusions, and the majority of these patients had undergone these procedures. Unfortunately, most of these patients had been suffering from chronic pain for more than 12 months, and quite a fair number had been suffering from pain for more than 2 years. This graph shows the prescribed pain medication. It's interesting to find that drugs like venlafaxine, duloxetine, amitriptyline have been first-line drugs in some patients who were prescribed medication for pain. Other drugs also included carbamazepine and pregabalin. As expected in our sociocultural context, a lot of patients had gone towards Ayurvedic treatment and acupuncture. And 2/3 of our patients, while receiving treatment from the pain clinic, had received these sorts of treatments as well. Okay, so this was our finding with regards to the prevalence of depression. 47.1% of patients in that pain clinic at that given time were found to be depressed. And 39.1% of them had met criteria for a very severe depressive episode. This was the finding with regards to sleep quality, and again 2/3 of the population had poor sleep quality. This is in spite of these patients, about 82% of these patients being prescribed benzodiazepines for their sleep. So we analyzed the depression scores with regards to age, gender, level of education, all of the socio-demographic factors, as well as the pain medications such as venlafaxine and amitriptyline. And we did not find a statistically significant difference with any of these socio-demographic factors. However, a statistically significant difference was seen in relation to the category of pain and depression. Therefore, depressed individuals who experienced a higher intensity of pain had higher pain scores. Also, there was a significant difference between the severity of the depression and the intensity of pain. That means more severely depressed patients experienced a higher intensity of pain. Also, we found a statistically significant difference in relation to overall sleep quality and depression, where participants meeting the cutoff for depression had poor sleep quality. We also found a statistically significant difference in relation to the intensity of pain, that is when pain is classified from 1 to 10, and poor sleep quality, where patients currently experiencing higher pain scores, such as pain scores of more than 7 points, were found to have a poorer sleep quality. We did not find, so the different components in the Pittsburgh Sleep Quality Index were also analyzed with regard to sleep quality, latency, duration, efficacy, and we did not find any statistically significant difference in any of these sleep parameters. So these were our outcomes and our limitations. Data from international studies tell us that chronic pain increases the risk of depression between 2 to 4 times in the general population. Depression studies in Sri Lanka has shown us that the prevalence rate varies between 6 and 10%. So this study shows that there is an 8 times higher prevalence of depression than the general population. Early recognition and treatment of depression will not only alleviate symptoms, but also reduce the need for pain medication, reducing overcrowding in pain clinics, and translating to reducing the burden of healthcare costs. We also know that when it comes to phantom limb pain, we found 8 such patients in our study, and the only definitive management for phantom limb pain is the mirror technique and CBT. And therefore, the establishment of multidisciplinary teams is a must in pain clinics in Sri Lanka. This study also highlighted the overuse of prescribed medications such as benzodiazepines in this special study cohort. Thank you.